So thank you very much for a kind introduction and the opportunity to speak today. And I will just pick up the slack where Dr. O'Leary finished, and I will take you through the what we call systemic treatment, which mostly represents the treatment with chemotherapy. We combine with the surgery for the best possible outcome in the treatment of ovarian cancer. So just go. So this is just to give you an information about the current situation in Ireland. This is the information from the annual Irish Cancer Registry report telling us that the ovarian cancer comprises approximately 4% of malignancies that are seen in females, and in the overall it's approximately slightly below 2% of all the malignancies that are diagnosed in Ireland these days. The truth is that the majority of women will have advanced disease at the time of a presentation. We see that reflects also the relatively poor survival at 5 and 10 years since the diagnosis that we still see. So even though that has improved and the trend continues, that there has been improved survival by approximately 10% in the last 20 or 15 years looking at the registry, it is still that approximately 35 patients would be well and alive at 5 years. So the survival is still not great. Why is it that majority of patients do come late? That's what Dr. O'Leary discussed before. It is the fact that most of the very early symptoms would be very subtle, and they would be easily dismissed by the patient themselves. They may present as like a slight pelvic discomfort, which only happens now and then. It could be just recurrent urinary infections, which initially are treated, such as, and that's why the early imaging and the improved pathway for the GPs to investigate these early symptoms may actually lead to earlier detection, or the detection of the earlier stages of ovarian cancer, where the overall outcome is actually reasonably good. So the other issue why it is a disease which is generally treated slightly differently, and the combination with chemotherapy and surgery is crucial, is that the most common route of spread of ovarian cancer doesn't happen as much through the lymphogenic spread, through the lymphatic stream, or the hematogenic dissemination through a bloodstream. But there is this dissemination, the spread among the surfaces of organs in the pelvic cavity and abdominal cavity. The hematogenic or lymphogenic spread happens generally later on, and we see that sometimes in patients with stage 4 disease. But compared to other diseases where we see patients with a liver or lung metastasis, we don't see that often in ovarian cancer. So it is the spread over the surface of organs which is the typical pattern of behavior of this cancer. And as been said before, most patients present with the stage 3 and then or stage 4 disease, and that's highlighted in red. So those patients who already have the disease spread beyond the pelvis into the abdominal cavity are patients with the stage 3 disease, and the patients where the disease spread beyond abdomen are patients with the stage 4 disease. So the standard of care remains the combination of a good surgery, and for vast majority of patients, it is a treatment with a systemic chemotherapy. We use the word systemic for chemotherapy, so I'll just explain what that means. It means delivery of the chemotherapy, generally through intravenous infusion, and the chemotherapy is then circulated to the involved areas by the bloodstream. However, it is a non-targeted treatment, so healthy cells, healthy parts of the body are affected also by the administered chemotherapy, and that's where the side effects of chemotherapy come from. There is also an alternative to administration of the chemotherapy systemically. There would be administration of the chemotherapy, what we would say locoregionally, in particular in the ovarian cancer, into the abdominal cavity. I'll touch on that briefly, but because it is a treatment which is rarely, very rarely used, I will probably not talk about that much. So just what are the major concerns the patients would have when they first come to see an oncologist with the new diagnosis of ovarian cancer? So after they get through the difficult part of the initial shock that they actually were diagnosed with such a serious malignancy, we would be obviously discussing the treatment options. And I'll focus a little bit more on the chemotherapy part. So as Dr. O'Leary explained previously, majority of patients would receive chemotherapy following the surgery. The primary debulking surgery followed by chemotherapy, this concept of systemic treatment we call adjuvant. By adjuvant, we mean that the chemotherapy targets that invisible microscopic disease we feel was left behind despite an excellent surgical outcome. We know that there is a benefit of adding the chemotherapy even to the treatment of the very early stages. So generally, if we were, say, who does not require adjuvant chemotherapy following primary surgery, it would be patients with stage 1A disease where only one ovary was involved, or stage 1B disease, and there are only patients who do not have microscopically identified adverse features. Adverse features are the characteristics which our histopathologists give the cancer on microscopic assessment. So they give us whether the tumor is high or low grade. So any patient with high-grade tumor, even for the stage 1A disease, generally would be recommended the adjuvant chemotherapy. Also, there are different subtypes of ovarian cancer, and some of these histological subtypes have more worrisome prognosis. For example, clear cell ovarian carcinoma. So in that situation, the adjuvant chemotherapy would be recommended even for the earliest stages. And there is evidence from clinical trials which suggests that the cure rates are improved with addition of the adjuvant chemotherapy, even to patients with a stage 1 disease. The chemotherapy would be then standard of care for all patients who have identified stage 2 or stage 3 disease. The other alternative that's been discussed before is the possibility of receiving the chemotherapy upfront. So some patients indeed do benefit from having the systemic chemotherapy delivered prior to surgery. And that concept is called neoadjuvant. And just to give you an idea how we discussed previously, or you heard it just a few minutes ago, that the degree of the interval debulking surgery or the degree of the primary debulking surgery really matters. This is just a visual picture, how 1 centimeter roughly may look. So it is indeed very important that such a surgery is done, but that 1 centimeter still represents 1 billion of tumor cells. So anything below that is less, but we do know that microscopically there are invisible cancer cells still in situ, which should be then targeted with the systemic chemotherapy. And we also know that the good surgery improves the outcome, and that's why it should be done in the specialist hand. Survival is as good with the concept of the chemotherapy after surgery or with the concept of the chemotherapy before and after surgery. That's what patients would frequently ask about, because they have a concern if the surgery is not done before, as is not done in the first instance, they may do worse. And it is indeed true that some patients may not have a response to the initial chemotherapy. But as explained before, these patients would be unlikely to benefit from surgery upfront either, because the disease, so to speak, identifies itself as a biologically badly behaved disease. We do know that the responsiveness to chemotherapy is an indicator of how well patients will do in future. So patients have a better chance to have a high-quality surgery with optimal surgical debulking, and they also are in a better physical condition to receive the chemotherapy, and they can have less complications following the surgery. So the standard of care would be that for the patients with early stage ovarian cancer, we would be recommending approximately 3 to 6 cycles of adjuvant chemotherapy. And in the advanced disease, the recommendation is that the patient should indeed receive 6 cycles of chemotherapy, but in some selected cases, the number of chemotherapy cycles can go as high as 8. We do not deliver more than 8 cycles of chemotherapy in either setting. And just for your own information regarding the administration of the chemotherapy into peritoneal cavity, so administration of chemotherapy straight into the abdominal cavity, we call that intraperitoneal chemotherapy. That is a treatment which shown to improve overall survival. But there is a lot of downsides to this treatment approach. Not every patient would be a patient suitable for this type of an approach. The patients who do benefit from this treatment are those who had optimal surgical debulking up front, and they would only have, if left behind, microscopic invisible disease. The toxicity of this treatment, however, is highly significant, because not only there is a local complications, but even though the chemotherapy is administered into intraperitoneal cavity, it still reabsorbs into the bloodstream through the surfaces, and it still has also the same degree of side effects that the chemotherapy would have if it was administered through the intravenous drip. So even though I mentioned this study here, it also mentions that there was only 42% of patients, less than a half, who were able to complete the full course of treatment. And it's not a treatment that would be routinely available in Ireland whatsoever, and even in the world it's only available in highly selected centers. So the chemotherapy, the concept of chemotherapy is what usually makes people afraid, because the side effects are concerning for most of the patients. Just to take you through the most important chemotherapy drugs. So since 1978, identification of a drug called cisplatin was one of the milestones in the ovarian cancer development. The cisplatin is a highly effective drug in the treatment of ovarian cancer. And later on, there was another drug from the same group developed called carboplatin, which is the one we would be using more frequently in the treatment, which has slightly more favorable toxicity profile. It's better tolerated by patients, does not have as many side effects affecting kidney function, affecting ears, hearing, tinnitus, late nerve toxicity. And then in the early 90s, there was a group of chemotherapy agents called taxanes identified, and one of them, paclitaxel, combined with the carboplatin, following a series of clinical trials, became the standard of care for the treatment in the adjuvant, neoadjuvant setting of the early stage ovarian cancer. So when patients do get through the first treatment, chemotherapy followed by surgery and completion of chemotherapy, or they have surgery followed by chemotherapy, thankfully, majority of patients do achieve what we would call remission, complete remission. And it is a question how long this remission can last, and would this be a permanent remission which would translate into a cure. So most patients would have these concerns, and while for patients with a stage 1, the cure rate is indeed over 90%, we still have a majority of people coming to us with a stage 3 when they have more than 2/3 risk that their cancer would relapse at a later stage. So what do we do in the situation that the cancer does recur? The treatment, which is the first choice of treatment, is again treatment with systemic chemotherapy, and nowadays the chemotherapy can be combined with some newer treatment approaches, which I will mention later on. So for the chemotherapy, the major deciding element for the physician to decide which chemotherapy agent we are going to use is the length of the remission. So we distinguish between patients who had no response to the platinum-based chemotherapy at all. We call them platinum refractory. And those would be the patients with the very worst prognosis, the ones who might not get to the surgery, for example, because they don't have the very initial response to the platinum. And then we have patients who have a relapse which doesn't happen for 12 months or longer. And these patients we see as the patients who are platinum sensitive. And we know they are highly likely to respond to platinum-based chemotherapy again. And the patients in between, where the remission lasts from 6 to 12 months, we consider partially platinum sensitive. And that drives the choice of a chemotherapy agent we would be using for the treatment of the recurrence. And as Dr. O'Leary mentioned, there is, for selected patients, a role for another surgery, but those are highly selected cases of patients who had high chemo response, who would still respond to the platinum-sensitive treatment. Patients who would, on scans, have preferably identified localized area of disease which could be resected, and preferably patients who have no ascites, no free intra-abdominal fluid. So just to give you an example, and I'm not sure how that, it's visible, all right. So these are the chemotherapy drugs that we would be using. So is it pointing? So the platinum-sensitive patients who had initial response to the platinum-containing chemotherapy and their remission lasts over 12 months, they indeed have, again, over 50%, around 50% chance to respond to the platinum again. And either re-challenging with the paclitaxel platinum, or the other very good regimen would be gemcitabine platinum or liposomal doxorubicin plus platinum. Those would be the drugs of choice. Also, the fact how people did with the previous chemotherapy matters, because some patients may have side effects which persist, in particular, for example, neuropathy, numbness, or pins and needles in fingertips and toes, which would be likely to get worse with repeated paclitaxel treatment. So the physician would not only look at how long the patient was in remission, which drugs were used before, but how patient did on the previous regimen, what degree of side effects were there, and what residual side effect there still may be. For the patients who are partially platinum sensitive and they relapse 6 to 12 months, they still have a chance to respond to platinum. So I would generally still use platinum as the treatment of choice. And then for patients who are platinum resistant and the relapse happens really quickly after completion of the first platinum line of treatment, we have a different treatment choices, but the preferred approach is to give one chemotherapy agent only, which has a lower toxicity profile, but we do know that the response rate, that is the chance to respond to that treatment, is relatively low. So those would be the liposomal doxorubicin, topotecan, and paclitaxel would be the drugs most frequently used in this setting, and that's talking of the standard, about the standard chemotherapy treatment. It is still true that the recurrent ovarian cancer is a difficult disease to treat. So when patients do not respond to chemotherapy, it is for the physician to judge what other options are there left. We will be talking later on about the options of clinical trials, which sometimes may be looking at the new treatment options. But in some patients, with the continued progression of disease, patients' condition deteriorates. And generally, if the cancer is not responding to chemotherapy line for two times in a row, or the patients are too unwell to continue, there might be a point at which the physician recommends that no further chemotherapy is given and the patients are managed in a symptomatic fashion. So talking the newer agents, so it's been approximately well, maybe 10 or 15 years since the anti-angiogenic agents were introduced into the cancer treatment. The agent we use nowadays routinely in a treatment of recurrent ovarian cancer and being looked at in the setting of the first-line treatment as well is a drug called bevacizumab, or under commercial name of Avastin. It is a monoclonal antibody which targets vascular endothelial growth factor. That's a major crucial factor in the ability of the tumor to build its own infrastructure. So it is building neovasculature, new vessels, which should supply the tumor with oxygen and nutrition in order to accelerate the tumor growth. So by blocking the vascular endothelial growth factor, we can achieve either prolongation of the remission of people with recurrent disease, and in the adjuvant setting, for highly selected patients, there may be a slightly improved outcome with adding the bevacizumab to the post-operative chemotherapy. So the vascular growth factors are released, and the bevacizumab is actually the main monoclonal antibody which can slow down the process of creating the new low-quality, quickly built vessels which should supply the tumor with the oxygen in particular and nutrition. The adjuvant improvement, so the addition of bevacizumab wasn't convincing in the studies where it was added to the routine chemotherapy, but it can be offered to patients who we know had suboptimally debulked disease. In the recurrent setting, the bevacizumab prolongs the remission achieved with the different lines of chemotherapy and can be added to the chemotherapy either in the platinum-sensitive setting, so with the platinum-containing regimen, or it can be left a little bit later on and combined with those single-agent chemotherapies we would use in the treatment later on. And then probably the newest approach, or the new drugs which show promising results in ovarian cancer, have been around for the approximately last decade in the setting of clinical trials, but only put to a routine clinical use approximately 3 years ago. And I'll be talking about PARP inhibitors. The one which gained the earliest approval was olaparib, but there are other drugs from this group of agents which are now available. So the discovery of the PARP inhibitors, or how this all came about, has a close relationship to the discovery of the inherited breast and ovarian cancer syndrome with patients who have the mutation in the BRCA genes. Why is there an association? We know that the patients who have the BRCA germline mutation are more likely to develop ovarian and breast cancer. And the reason for that is that the BRCA is one of the major genes in the body which guarantee self-repair of DNA for cells. So what happens in our bodies, there is lots of different changes which happen to our cells all the time. And if there is a DNA mutation which is significant and may lead to cancer, with the correct repairing mechanisms or the correct recognition of this cell being a wrong cell, it leads to a natural cell death of this cell. So the cell just is programmed to die. It is usually the lack of the controlling mechanisms which lead to cancer development. And if these cells, the patients with the BRCA, are lacking in mechanism to repair the DNA damage, they are more likely to develop the cancer. But when that cancer actually happens, those cancer cells are also deficient in DNA repair. And if we use drugs which are DNA damaging, these patients respond very well to these drugs. And because the cancer cells cannot repair the DNA damage and they die. That's why platinum has been highly successful, because platinum is a drug which targets DNA. So we know that the patients with BRCA mutations have a good response to the platinum agents. Their remission is usually longer, and we know that they do better. The patients with the BRCA2 mutation seem to do even better than the patients with the BRCA1 mutation. So because there is impaired ability to repair DNA damage, these patients have increased sensitivity to platinum. And if we look at, and Dr. O'Leary spoke about this, the cancer cells would respond or would react to chemotherapy. They are most sensitive to the effect of chemotherapy if they are undergoing a process of division. The most important bit is this. So in order for one cell to become two, the cell needs to duplicate the genetic material, which is the DNA. And when that process of DNA duplication happens, that's where the DNA damaging agents are actually acting against those cancer cells. But it is not all of the tumor which undergoes division at the same time. It's always a small portion of cells which are dividing. That's why we give the chemo in cycles, because once we kill off a portion of the tumor, what does the tumor do? The tumor brings some of the sleeping cells into the division phase to replace that missing bit. And that's when the next cycle of chemo comes in, and that kills those dividing cells again. So if these cells can be targeted here and they can't repair the DNA damage, then we are looking at the longer cancer response. And that's where the PARP inhibitors come through. So in a normal cell, we have several different mechanisms of DNA repair. The homologous recombination is the one which is controlled by the BRCA mechanism. If that is missing, this DNA repair pathway doesn't exist. And what the PARP inhibitors do, they block the alternative pathway of repair. So in a patient who have BRCA mutation and they have a cancer which already lacks this DNA repair here, and we block with PARP inhibitor the alternative DNA repairing mechanism, that's where we have what we want, and that's the cell death, or the double lethal hit, as these treatments are so to speak called. So that is one of the really good discoveries. However, in order to achieve the best outcome, the patient should have the BRCA mutation. So the best outcome is for patients who have identified BRCA mutation. And we know that there's different subtypes of a breast cancer, but the one which is most likely to have the BRCA mutation is the high-grade serous papillary ovarian cancer. And while there is lots of different molecular subtypes identified these days, we know that there is only a certain portion of the germline inherited BRCA mutations, but we also know that some patients can have the BRCA-like profile, so they can have somatic mutations which only happen within the tumor setting. So those are patients who did not inherit the deficient gene from a relative, but it's a sporadic change which happens within the tumor environment. So the treatment with PARP inhibitors is now emerging. It has been approved and is also available routinely in Ireland for patients with ovarian cancer who do have identified BRCA mutation. And it can be used in any line of the treatment. So patients who have recurrent disease, they can have the PARP inhibitor even if they already failed 3 or 4 lines of chemotherapy. The FDA Food and Drug Administration also approved PARP inhibitors for maintenance treatment in patients who experience recurrence. They receive platinum-based chemotherapy and they have a response, then commenced on the maintenance PARP inhibitor. This treatment is currently not yet reimbursed by HSE in Ireland, because the data from the clinical studies are pending and we don't know how well it would impact on the overall survival of patients. So I've been talking a lot about the clinical trials, so I will just give you a very brief intro about what actually is the clinical trial and where to look for information in Ireland. And also I would probably talk to you about which clinical trials are available at the moment. So it's a common knowledge among oncology that the clinical trials, or the, so to speak, clinical research in Ireland has been united into the organization Cancer Trials Ireland. It was previously known as ICORC. It has been renamed approximately 2 years ago to Cancer Trial Ireland. This is the website. It's a screenshot of a website of Cancer Trial Ireland. And as you see, there is a patient section information. There is a group of gynecological malignancies. There is information for clinicians as well. So it's a publicly accessible website where patients, relatives, physicians, whoever is interested can look for information. What is a clinical trial? Basically, all I've been talking about here, and Dr. O'Leary in the talk, is the treatments we use are all based on some evidence. And to justify the treatment with chemotherapy and the risk of all the side effects, we have to have some evidence that it is a treatment which actually works. And that's where the clinical trials are important. We would not be using a treatment which does not have the scientific evidence that it actually can lead to improvements. So a clinical trial is a research study which is performed in humans, and it's performed to answer a specific question. Which treatment, which drug or a treatment strategy can be better than the current existing ones? The clinical trials come in different phases. So when, for example, a new drug is being introduced into a clinical practice, it has to go through a series of laboratory and preclinical and animal models data before it actually can be safely offered to humans. And then the first phases of a clinical trial are the ones which ordinary patient is unlikely to be offered. It's a clinical study when the drug is introduced to a human patient for the first time. And it is a drug looking at the dose which would be effective and the toxicity profile, and in a later setting against, for example, which malignancies it can be effective. Then, if the drug fulfills the requested criteria, is moved into the phase 2 clinical trial, which can be still looking at what types of malignancies it can work again, or if there is a particular promising type of cancer, the clinical study phase 2 is performed to assess whether there actually would be a response to this type of a drug. And the clinical trials which are most likely to be offered to patients in Ireland are the phase 3 studies. So a drug which already has proven to be efficient in a certain setting, the phase 3 studies generally compare whether the new drug, either alone or added to the standard of treatment, would be better than the standard alone. And patients do have an option to become a part of the clinical trial, because that can sometimes offer them a good option when they are toward the end of their treatment and the options are getting thin. Or it may actually guarantee them access to an early new treatment which is showing very promising results. So the clinical trials which are open in Ireland at the moment are these 4. The ones which are blue are actually available in Galway University Hospital. But for each clinical study, there is a particular setting in which the study is done. So this is a good example that we are looking at study which can be offered to patients who already had quite a significant amount of treatment. So this is looking at a new agent which would be compared to a physician's choice of chemotherapy in women who already have been treated for relapsed cancer and they have gone through a certain number of lines of treatment. The Javelin is looking at one of the new emerging approaches to cancer. It's looking at what we call immunotherapy or checkpoint inhibitors treatment, looking at the drug called avelumab, which is a monoclonal antibody against PD-L1, which is a program that ligand 1. That's a treatment, in general we call it immunotherapy. So the principle of that treatment is to activate people's own immunity system to recognize the cancer cells again as a foreign entity and induce immunity reaction and eliminate the cancer. And then in the early setting, we have the ICON 8 study, which is looking at the different fractionation of chemotherapy paclitaxel at a weekly schedule and bevacizumab, and the PRIMA study, which is looking at adding the PARP inhibitor niraparib into the very early treatment, the first treatment for ovarian cancer. So women who had platinum response, had successful surgery, completed their chemotherapy, are offered niraparib as a maintenance versus placebo, and they would be evaluated whether the early addition of the PARP inhibitor for patients who had a response to platinum would lead to survival or progression-free length of remission improvement. So these are actually available in Ireland. Just another screenshot from the Cancer Trials Ireland. With the initiative Just Ask You Doctor, you could see that the information is easily accessible. It can be looked up by any clinician. You can visit the Cancer Trials Ireland yourself, or you can use the nurse line free phone offered and supported by the Irish Cancer Society. So just in summary, the chemotherapy still remains the backbone of treatment in ovarian cancer. But there are new emerging treatments, and they would be highly beneficial, I believe, in the specific subgroups of patients with ovarian cancer. And it is the sad truth that the recurrent disease is still difficult to treat, and it's still causes a significant number of deaths among patients. But hopefully with the joint research and the interest from public, etc., there will be better outcomes coming up soon. So thank you for your attention.